Hello everyone, welcome to our February webinar on Pediatric Flatfeet. My name is Meg and we're very excited to have you here with us today.
My name is Kat, and before we get started, we're going to run through a brief bio about Dr. Graham, as well as share some information about the features our webinar has available for you guys today. Dr. Graham is a board-certified podiatric foot and ankle surgeon and the inventor of the hypercure sinus Tarsai stent. Dr. Graham founded Gramatica, a medical device company, in 2003 and received FDA clearance of hypercure in 2004.
Before we hand you over to Dr. Graham, please direct your attention to the bottom of your screen. At any time during his presentation, if you have any questions, please enter them in the Q&A section, as well as your comments into the chat field. Throughout Dr. Graham's presentation, Kat and I will be chatting with you to assist when needed. Also, please be advised we will be posting in other languages to accommodate our international attendees.
Now, without further ado, we are proud to present Dr. Graham and his presentation on pediatric flatfeet.
Well, thank you so much for that intro, and I'm so happy to be with you today. Excuse my voice, I caught a cold on one of my recent trips, so hopefully you can all understand me. Pediatric flatfeet is such an important disease process, and there's just so many myths and misconceptions out there, and so that's why we were really excited to present this topic to you today. So the big question is, pediatric flatfoot, is this a normal variant like a lot of the profession, a lot of physicians and medical professionals say, or is this a disaster waiting to happen? So some of the objectives that we have today is to explore what are the pathomechanic components of a flat foot. Is there any science to support the theory that children with pediatric flat feet will just outgrow this condition? Finally, then, we're going to look at secondary conditions linked to flat feet and review the treatment options. So the first part of this is, what exactly is a pediatric flat foot? Because this is a question that I always ask everywhere I go. If you don't know what's wrong, how are you supposed to fix it? So we take a look at these children, and yeah, I mean, they have a fat foot, but does that necessarily mean that it's a flat foot? So we can take a look at this child's feet and we see that there's no medial longitudinal arch. But when we consider or observe the bisection of the leg with the bisection of the foot, specifically the second metatarsal, we see that this is an aligned foot. So this is not a pathologic foot. This is just an observation of a child's normal foot that they're going to look like. So this is one of those normal feet. Now we get into this situation over here. Are you going to think that this is normal, abnormal, a fat foot, or a misaligned foot? And so that's something that we need to take into consideration and see what kind of treatment we're going to eventually offer this patient. So what's a flat foot? It's there's a lot of different definitions out there. A lot of them just look at the longitudinal arch, the medial longitudinal arch, and see that it's lower than normal, and they call it a flat foot or pes planus. Then there's other classifications that talk about the valgus portion of a flat foot. So it's the hindfoot valgus that leads to foot pronation, and again, the lowering of the medial longitudinal arch. I don't know if I really, yeah, there's components of that, but we're going to dig deeper into that. But let's keep going. So how are we going to diagnose somebody with a flat foot? Are we just going to have that child stand and take a look at the medial longitudinal arch? We're going to look at the back of the heel to see if it's rectus, varus, or valgus. Or maybe it's just that there's a too many toes sign. We should have the child walk and see what happens with their medial longitudinal arch. And again, look at the calcaneal valgus and too many toes sign. And then we have finally the range of motion testing. So this is what a lot of pediatricians and physical therapists, chiropractors probably look at with the kids' feet, and then they try to say, is it normal or abnormal? Some people, they have this podoscope, which they look at the plantar footprint of the patient, and with this alone, then they try to diagnose, is this a flat foot or a normal foot? But does this accurately depict the osseous alignment of the foot and ankle? No, absolutely not. So this only gives just one very, very small, insignificant picture of an overlying misalignment deformity. Now, there's also something else called the foot posture index. And there's a lot of different things that are included with this. However, the only problem with that is that it's external observations only. And the problem with that is that it does not give us any kind of specific measurements. And it's going to vary from observer to observer. Another study that's out there looked at navicular drop. And so they measure how much the navicular drops, looking at the navicular tuberosity. And so what they say is that a navicular drop of 6 millimeters is diagnostic of a flat foot. So if you don't have that, then that drop, then that means that you have a normal foot. And there's even a validation of this. So that's going to bring us to one of our polling questions here is if you think that this is something that can work. But before we get to this polling question, I know that we have another one. So I'm going to go back to this one and say, do you feel that it's your obligation as a physician or as a healer to present treatment options that prevent or resolves the progression of a secondary disease process? Because, you know, this is why we're out here, is to, you know, again, have all of these different options for our patients. So let me give you guys a couple more minutes or seconds to do this one. Okay, so let's end this one. And yeah, surprisingly, 100% of you say that, yeah, we want to try to give a treatment option that is going to help prevent those things. So let's continue on here to our next one. Oh, that's the same one, right? Oh, here we go. Here, right? I'm getting new to this. Oh, here we go. So that's great. We can put these in different order. Okay. So do you think that a lower than normal arch happens because of the drop navicular? Is that normal? Is this a normal finding that a drop navicular is going to lead to that it's normal? Okay, we're getting some mixed results here. So lowering of the medial arch of the foot should be considered normal. That's what I'm trying to get at here. Okay, well, surprisingly, to me at least, we have several, almost half, say that a lower than normal arch is a normal finding. Which, okay, so I guess we're gonna have to spend some time on this to see if that really makes any sense. So, okay, well, let's keep moving on here. So when we take a look at this kind of a thing, they said that less than the 6 millimeter drop is considered a flat foot, not abnormal foot. So that tells us that a lower than normal medial longitudinal arch is a pathologic finding and not normal. So any of you that agreed with that, yeah, that's true. So lowering of the medial longitudinal arch is not normal, that's abnormal. So we take a look at this foot, definitely lower than normal arch, the navicular has fallen down. And so considering the observations that we talked about before, can you diagnose this person with having a flat foot? Well, from observation, yeah, definitely. But there was a guy a long time ago, Dr. Rankin, who invented this amazing machine called the X-ray. And so really the best way to diagnose somebody with a pathologic foot condition is not by simply observations. So that's going to give you clues, but that doesn't tell you what's wrong. So what we need to do, the only way to definitively diagnose somebody with a misaligned flat foot is to take X-rays. So otherwise it's kind of a guess, but you don't know for sure. That's why we take blood work and have CTs and MRIs, everything else. That's where you get the true diagnosis. So one of the most important parts when looking at the difference between a normal foot and an abnormal misaligned foot is, and so we can see the clinical photos of the feet. The top one is abnormal aligned, and then the bottom one, this is a normal foot. Nobody can, it'd be impossible for anybody to say that this top view, this top foot is normal. I mean, yes, okay, there are people out there that said that that's normal, but give me a break. I think those same people say that it's okay to drive with flat tires on your car. I mean, that's just like wrong. So the difference between a normal and abnormal foot alignment depends on the alignment and stability of the talus on the calcaneus, or the loss of the stability and alignment of the talus on the calcaneus and navicular. So that's the only difference between these 2 feet. So let's dig into this a little bit more. So just think about this. When the patient's foot is in the air, there's no weight, and the talus is aligned on the calcaneus and navicular. But then as soon as the patient becomes weight-bearing, we see then how the arch collapses. This is not normal. This is a pathologic finding. So now we're going to take a look at this x-ray, put the x-ray in motion. And so the difference between the aligned hindfoot and misaligned hindfoot depends on the stability and alignment of the talus on the calcaneus and navicular bones. So because of the misalignment, this partial dislocation of the talus on the calcaneus, this is leading to a chain reaction of strain and tissue pathologies within the foot and ankle. So again, for those of you that are not familiar with this kind of visual and this kind of thing, we see that with no weight on the patient's foot, they have a nice arch. And then once they put weight on their foot, the arch collapses. So again, the only difference is the stability and alignment of the talus with no weight on the foot, and then the partial dislocation of the talus on the calcaneus and navicular. So it's that way. It's not that the calcaneus deviates, which leads to talar displacement, or that the navicular drops and then the talus drops. That's not the situation. It's the other way around. It's the talus that partially dislocates on the calcaneus that creates the valgus of the calcaneus, and also the navicular is forced plantarly because of the forces acting on it from the talus. So again, we can just definitely see that. All right, so let's go to our next polling question, which is, and this is really important, I want to know how many of you believe that a child, here we go, with a child with a misaligned foot, like the one on the left here, just has to wait long enough before then the talus just magically restabilizes and realigns on the calcaneus, and that the navicular then is elevated. That's what a lot of literature says. That's what pediatricians are out there telling so many parents, is that, yeah, you just have to wait long enough and your child's going to outgrow this condition. So, okay, good. We're getting a lot of answers here. This is great. So far, we have very few that are agreeing with this statement, and I'm happy to see that. 89% of those watching this right now disagree, and only 11% agree. So let's look at this. Let's think about this for a second. And so looking at like some of the literature that's out there. So this is looking at the longitudinal arch of 441 normal subjects. Again, normal. I don't know how they're saying that they're normal. What they found is that flat feet are usual in infants, common in children, and within a normal range in adult feet, which doesn't make any sense. But anyway, so that's what they said is normal, because they found that. So imagine that you went to a senior citizen's house, place, nursing home, and took blood sugar levels from all of those people, and you said, well, you know what? The majority of people in the nursing home have elevated blood sugar levels, and because so many people have that, we're just going to say that it's normal. Of course it's not normal, it's pathologic. So that doesn't make any sense. So going back, so we're going to continue exploring the whole thing about doesn't make any sense. So this study here talked about how we diagnose those flat feet. And we have to use validated angular measurements on lateral and dorsal plantar x-rays. And when we do that, we find that there's a lot of different variants. Sometimes there's just a single plane deformity of just the talus dislocating on the calcaneus. Sometimes there's going to be midfoot collapse, especially at the first ray, hypermobility. there could be a lower than normal calcaneal inclination angle, but then other times patients can have a high calcaneal inclination angle and still have the partial dislocation of the talus on the calcaneus, resulting in an abnormal foot biomechanics. So this is a very complicated process, and I think that that's why there is so many myths and misconceptions out there. Now, what is some of the literature supporting that children can outgrow this condition? Well, there's some really ridiculous studies, and I have no idea how they actually got published. Here's one that was in Journal of Bone and Joint Surgery, the American version of this. And so what they did is they took a look at patients with flat feet, and they made some different radiographic measurements. There's 568 feet, and what they found is that, and they just took an x-ray, basically it was a year apart, and they found between the first year, from the initial stage of the x-ray and about a year later, that there was a 1.7 degree decrease in the telonavicular coverage, and the first metatarsal angle decreased by 2.1 degrees. Which sounds great. After 1 year, we see that this is decreasing. However, the only problem with this is that they didn't say what the standard deviation was. And if we take into consideration the standard deviation, I'm sure that it would have wiped out any of those degrees of correction. So this does not definitively say from those two measurements that a child can outgrow this condition. That study was published in 2013, and since then, there's been no other follow-up studies, which they should have done at 2 years, 5 years, 10 years, to show that the talus actually then realigned on the calcaneus and navicular. So this study is basically thrown out. Here's another study from 1980, quite a while ago, of 50 children, and this examiner gave these children some foot orthotics and showed after 1 year that there was a 0.41 degree change in the measurements, which sounds great, but again, what is the standard deviation of this? And it's half of a degree. That is insignificant. There's no follow-up studies, and this is only an immediate change, and I wonder why. Well, we know that there is absolutely no way, and I don't care what kind of device you have, that a foot orthotic is going to reverse this transverse plane or sagittal plane telotarsal dislocation deformity. There's no literature to support that the talus can be stabilized and realigned. And so sure, you can have these half of a degree changes, but that is just insignificant. This is a huge myth that's out there, that foot orthotics can reverse, prevent, or restore hindfoot biomechanics and realignment. There's just no evidence to support that. So this is another thing that a lot of children are told, or parents are told, to go out and buy these special shoes for your kids. But here's a study that was back in '89, and it showed that after 3 years of wearing special shoes, there's absolutely no improvement in the kids' feet with flexible flat feet. So after 3 years, we're supposed to have this spontaneous correction, although this study already proved that there is no spontaneous correction. Here's something else too, is that the use of these orthotics and shoes, it's not only ineffective and uncomfortable for children, but it's also associated with lower self-esteem, because they know that they have this physical deformity that is severely affecting them. It's affecting their quality of life. So not only do we have physiologic problems, we also have psychological problems that are associated with these pathologic pediatric flat feet. So we have the psychosocial development of these kids is also affected, and later on in adulthood, it also shows that it demonstrates in this study a poor experience in childhood, and that it can lead to a vulnerable child syndrome. So that's not good. So that's why we have more than just physical symptoms. We have psychological symptoms that have been proven to be associated with pediatric flat feet. So with this study here too, this other one is a critical review of the treatment of pediatric flat feet. It showed that conservative care has, there's very limited evidence for any kind of efficacy that it helps children. So again, it just doesn't really make any sense that we should be offering conservative care. It doesn't work. So another study too, corrective shoes for flatfoot had no effect, zero effect. So when we take a look at the literature that's out there, and it says that the kids are supposed to outgrow this, and here we have mid to long-term studies showing that even with the corrective devices as orthotics and special shoes, that there's absolutely no correction. So there's no evidence to support that orthotics or special shoes work and that there is no correction, which makes total sense. So how can you ever believe, I mean, it's so ridiculous. How can you believe that a child is going to magically outgrow this condition and that their feet are going to be perfectly straight later on? It's not a normal foot. So how many of you out there actually think that this is a normal foot? And again, looking at the literature and looking at a lot, there's probably 80% of the medical professionals out there would take a look at these feet and say, well, just because this person has no physiologic symptoms, this should be considered normal and that no treatment should be initiated. Well, what do you see with these feet? I'm going to tell you what I see. I see at least 6 orthopedic pathologic deformities that you cannot say are normal. This is a calcaneal valgus. That's a pathology. That right there tells me that we have a abnormal foot alignment. We have a forefoot valgus, same thing. Too many toe signs, pathologic. Medial talar head bulging, pathologic. This person's going to have an abductory twist, which is an abnormal finding. And also, I bet everything that I own that they're going to have a functional leg length discrepancy, because how can their limb be the same length when the talus is partially dislocating on the calcaneus and navicular? So we have 6 different pathological findings just from this one observational, just looking at these feet. So you cannot say that this is a normal foot alignment. It's pathologic. So now what I want to do is use your X-ray vision and think about what is going on in this patient's foot. So when the talus partially dislocates on the calcaneus, this is going to lead to an increased strain on the spring ligament. It's going to increase the pressures within the tarsal tunnel and porta pedis. It's going to increase the strain on the tibialis posterior nerve and tendon. It's going to alter the Achilles tendon pool. It's going to put a stretch on it. It's going to increase the strain to the plantar fascia by at least 33%. And then we already know that misaligned feet have a negative role in the mechanics of knee, hip, and back alignment. So how can this misaligned feet ever be considered normal when we have all of these different pathologies that are associated with it? So this myth of autocorrection is absolutely absurd. There's never been one case study, not one, showing that we have this pathologic hindfoot alignment where the talus is partially dislocating on the calcaneus and navicular, that it looks like this video on the right-hand side. There's never been one study. So that's absolutely a myth. It's false and unproven. Why? Why can't this happen? So think about it. We have this dynamic deformity that happens thousands of times a day. So we look at how many steps are taken in 10-year increments. So by the time somebody, let's say they're 20 years old, they've taken 36,200,000 steps. So that's over 36 million times that the talus is partially dislocating on the calcaneus. So the ligaments, the tendons, the joints they are not capable of somehow magically preventing this excessive hindfoot motion. So now let's fast forward this patient to when they're 60 years old. Now they've taken 108 million steps. So we have Wolff's and Davis's laws of tissue pathology that are taking effect. We have bone spur formations, the ligaments are getting stretched out, the tendons are stretched out, we're getting osteoarthritis within the joints, and now we can get some stability in the foot. But again, this foot is not better, it's only worse. So that's why these children with pediatric flat feet, they will never get better, they will only get worse. So is there any more support to show that pediatric flat feet is a bad thing? Well, we have this kinematic analysis report that shows that kids with pediatric flat feet have they're going to develop metatarsalgia and other plantar foot pathologies because of the abnormal weight-bearing forces acting on the bottom of the foot. Again, this study here goes back to the gait cycle and showing that they have an altered gait, and it's this dynamic functional change in their lower extremity because of their misaligned hind feet. So it's not good. And we know for the longest time that an overpronating, misaligned foot, the subtalar hyperpronation, leads to hallux valgus, tarsal tunnel syndrome, metatarsalgia, posterior tibial tendon dysfunction, arthritis within the foot and ankle, Achilles tendon pathology, knee pain, hip pain, back pain. So how can we say that we should disregard these children with misaligned feet, that they never cause any symptoms? So that's why it just blows my mind when we have these studies out there and these physicians like Mosca that say that a flexible flat foot is just normal and you should never have to worry about it. That's absolutely absurd. So here's another study too of the state of art review, and this is recent, this is 2016, that they claim that it resolves by adolescence, even though there's absolutely no support of that. So this is fake news here, that this just does not work, and that it's usually painless and that there's no functional consequences. How can they publish this? How can they ignore all of the literature out there that says that there are functional consequences of this disease process? Pediatric flat feet is a orthopedic disease. It is not normal. So these papers that say that it's normal are absolutely ridiculous. And here's something else too that's even worse, that we really don't even talk about, is the relationship between flat feet and pediatric obesity. And so if you have flat misaligned feet that hurts your legs, your knees, and back when you try to go out and exercise, well, you're going to become less active, you're going to gain weight, and then that's going to put more stress on your feet, and then you're going to have all the other metabolic conditions that are associated with that. So we have all this literature that says why misaligned pediatric flat feet are a bad thing. Now, a lot of literature, they take a look at the position of the navicular, and they say it's the navicular drop that leads to a lot of the onset of symptoms. And so that's what this study was showing here. So it's the navicular bone displacement. So we have to take a look at, why do we get excessive navicular bone displacement? So some people argue that it's because of the weakness of the spring ligament, or that the posterior tib tendon has just become weakened and overstretched. Well, those things do occur, and they are known to be associated with a flat foot, but they are secondary disease processes, not primary. Think about it. Why would a healthy child's ligaments just become overstretched and weakened? Well, we have to look at the stability of the hind foot, and the stability and the alignment of the foot begins with the osseous alignment with the articular facets between the talus and the calcaneus. The ligaments are secondary supportive structures. Within the ligaments, we have neural structures that send a signal to the spine that stimulates muscle and tendon contraction to help provide stability to the joint. But when you have a joint dislocation deformity like this one, no matter how strong the muscles, ligaments, and tendons are, they will never be strong enough to overcome the osseous dislocation between the talus and the calcaneus. So eventually those ligaments, tendons, and muscles become overstrained, and then they become also pathologic. So let's move this ahead. So let's get to this other polling question here, I guess. We made these, so we should use them. So do we have any, so let's launch this one. Do you know of any longitudinal studies that have shown improvement of the medial longitudinal arch without any intervention? So again, we're looking at studies that show that without doing anything, that the navicular, and let's say a 1-year-old that has fallen, once they become 18, that navicular is elevated. So just give you a few more seconds for everybody else to get in. Okay, well, so we have 17% of the people say that there are at least 5 studies that show that. I'd love for you to, any of you that answered 5 studies, please submit those studies to me so that I can take a look at them. I'm in agreement with the 83% that there are 0, because I'm not aware of any studies that show that. What I know is that they get worse, not better. So let's take a look at symptoms, because this is another aspect of pediatric flat feet that people say, the pediatricians and other pediatric orthopedic surgeons are out there saying, well, with those pediatric flat feet, you're never going to develop any symptoms, and so there's no reason for us to treat your feet because you're asymptomatic. And we're going to talk about that later on as well. But let's think about this. Now, absolutely, there are so many children out there that have 0 symptoms with their foot and ankle. And maybe it's true that even in their adolescent, early adult, or even midlife, they have no symptoms whatsoever in their feet. However, we can't just be have tunnel vision and only think about the symptoms within their foot and ankle. The foot's the foundation to the body. And if you have a misaligned foundation, that then can have repercussions up the musculoskeletal chain. So let's take a look at this. So you have to be careful if you're ever walking behind me in an airport or in a Las Vegas hotel. So let's look at this child who, look at, he's going to play again. I mean, again, so he's walking in his flip-flops here and probably doesn't have any symptoms, but now he's 80 years old. At this point, his feet are trashed. He's already had both knees replaced, 2 hips replaced, and back surgery. So this is just an accident waiting to happen. So did he outgrow this? Absolutely not. Do you think that this led to negative lifestyle and physical problems with this guy's life? Absolutely. So the symptoms are going to show up eventually. It's not if, it's when. So what kind of symptoms do we see in children? They have growing pains. Why do they get growing pains? Well, nothing should hurt when you grow. What this is a periostitis, where the lining of the tibia is being overstretched during the day because the muscles are having to work so hard to try to recreate the arch. So once the child gets off of their feet and they go to bed at night and they're not walking anymore, then that's when the pain sets in. So usually the tissues will eventually be able to withstand those forces, and that symptom can kind of just can go away on its own. Then we have a lot of kids that are out there that are playing soccer and they end up with calcaneal fasciitis. Why does that happen? Well, think about it. You have the growth plate that on the back of the heel, and what attaches to that? It's the Achilles tendon and also the plantar fascia. So somebody with a misaligned foot is going to have an abnormal pulling on the growth plate of the calcaneus. And then that leads to excessive motion and forces on the growth plate, and they end up with this inflammation. What's the treatment? Is the treatment out for the kid to go out and run as much as he can? No, weight-bearing activity increases the pain. So what's the treatment? Non-weight bearing in a cast. So once the child can potentially outgrow this, or maybe we can decrease the forces as much as we can with a custom-made arch support, that can help. Or a lot of times the poor kid just has to give up his sport, and that's a shame. Other kids develop any kind of just generalized foot and ankle pain. Of course, there's the psychological symptoms. This is something that I always ask the parents is, how is it when their child runs with the rest of their friends? And they said it's embarrassing because they always come in last place. No matter how much they try to run and jog and they try their best, they're always last. And the reason for that is because their leg muscles are having to work 4 to 5 times harder than their classmates that have a good, stable foot and ankle alignment. So when the child with pediatric flat feet is running, it's like they're running 10 kilometers or 1 mile versus everybody else that's just running 1 kilometer or 1 mile. So think about that. And then you have also the other side effects of pediatric obesity. They're trying to diet, and one of the biggest things with how to treat pediatric obesity is get the kids to get out and run and jog and be active to increase their metabolism. But how can you try to be active when you're punished for it? The more pain that you have when you try to go out and exercise, well, that's not encouraging. So it's just easier to sit back and just play video games and watch TV. So it's more than just those, again, the physical symptoms. You have the mental symptoms that are associated with that. So then the other symptoms that happen later in life is that a lot of the kids just have curbed the activity level. But what do we start seeing is the development of pediatric flat feet, getting hammer toes. Maybe they are able to try to run and jog, but then they get shin splints. They get functional induced symptoms. They realize that the more active they are, the more pain they have. They can start developing knee pain, hip pain, and back pain. And no child should have these kind of symptoms. And then maybe they're these promising athletes that they have a great potential. And then in high school, they blow out their knee, or in college, they could have had a great scholarship and they're going to go to the professionals, but now they blew out their knee because of their bad foot function, even though they never had foot pain, but those symptoms showed up as knee, hip, and back problems. So the connection has been proven. So the symptoms, again, they're continuing and they're only going to get worse. So now we get to early adult, and what do we see with early adults? Well, again, their knee pain is getting worse. Maybe because of their shin splints, they've stopped running. They're going to the chiropractor because their back is hurting them. And why is their back hurting? Because of pelvic tilt. Why do you get pelvic tilt? Because of a functional leg length discrepancy. And if you take, why is it functional versus structural? Is because if you took measurements of the femurs and tibias of both sides, they're the same. So the only reason why we have a functional leg length discrepancy is because of the partial dislocation of the talus and the calcaneus. And then we see other foot ankle deformities that are progressively getting worse. Bunions are getting worse, hallux limit is getting worse, hammer toe is getting worse, and so on. So now we hit that 35 to 50 years of age. Now a lot of people are coming in with heel pain, with plantar fasciitis. What is the number one etiology of plantar fascial disease? It's because of the strain of the medial band of the plantar fascia. Why do you get strain of the medial band of the plantar fascia? Because of the overloading of the medial longitudinal arch that never went away. That was supposed to have spontaneously outgrown. So there's literature to support that. People are having bunion surgery, hammer toe surgery, and it's possible that they had this when they were even younger than 35 years of age. And guess what's happening now? Those bunions are coming back. The hammer toes are coming back. Why? Because nobody ever addressed the underlying etiology, which was the pathologic hind foot motion. Patients are going to the chiropractor because of their chronic back pain, and there's a role for chiropractic care. The only problem is if you have a paper clip that keeps getting bent and you bend it back into place, eventually it's going to break. So what happens after a while of those chronic manipulations is that the ligaments are pulling abnormally on the spine. You get herniated discs. Why do you get herniated discs? Because of the imbalance of forces that are acting on the vertebrae that's associated with the misaligned feet. So again, you can have back surgery. When you have back surgery, you go in and infuse L4, L5. That only works for about 10 years because now the motion that should have been occurring there is being forced on the vertebrae proximally and distally to the fusion site. Maybe you've had an arthroscopic knee surgery, which gave you some temporary relief, but this is not a cure-all. And so what ends up happening is you're going to have another surgery or you're going to end up with a knee replacement. And of course, you have metabolic diseases that are happening now because of your inactivity, you've gained weight, and when you gain weight, then that predisposes you to becoming a diabetic, have high blood pressure, heart disease, and even further obesity. So what's the number one treatment recommendation for syndrome X, this metabolic diseases? This is to get out and exercise. But like I keep saying, how can you exercise if you're punished for doing it? So later in life, when you're 50 to 80 years old, you come in and your feet are absolutely blown out because now you have this adult acquired flat foot, which is the most ridiculous diagnosis ever made. These people have had their flat feet for their whole life because they never outgrew them, like their pediatrician told them, and now they're very symptomatic, and it's almost like this end stage flat feet. Their posterior tib tendon is blown out. They have chronic pain to their knees, hips, and back. They keep taking all of these great pills and injections and surgeries, but the pain just never goes away. And why? Because again, Wolff-Davis laws, the tissues are reacting to the excessive strain and they're becoming more and more pathologic. The heart disease, diabetes, hypertension is all getting worse and never goes away. So think about this. You say to that child, don't worry about your flat feet, you're just going to outgrow it. And then now, when these people are 70, 80 years, we end up with this end stage flat foot. Now what are you going to do? You can't go back and sue your pediatrician. He's probably not even alive anymore. So now we're end up with this mess. It's a mess. How are you going to fix this? So again, as a physician, our roles are to prevent diseases when we can, not to wait until their end stage and then initiate treatment. That doesn't make any sense. So let's talk about realistically, and this is, I'm very passionate about this because this is just craziness that's going out there. Is this what you consider to be the standard of care in the treatment of pediatric flat feet? That when a parent brings their child with flat feet to you, you should lie to the parents and say that, don't worry, your child's going to outgrow this condition. There's actually some articles that are out there that say that the number one responsibility is not to treat the condition. The number one role of a physician is to convince, this is what this one paper said, to convince the parent that no treatment is necessary, knowing all of the pathologies associated with flat feet. So is it within the standard of care to tell these parents that, don't worry, no treatment is needed? Just let your child keep walking on these broken feet and no treatment will ever be needed. That doesn't make any sense. Or how about this one? That, no, let me sell you this magic arch support that you're gonna have to pay $500 to $800, and this is going to magically fix your child's feet. It's going to stabilize the talus on the calcaneus, and everything's gonna go away, even though there's no literature to support that. The literature actually is against that. The literature says after 3 years of using these custom-made orthotics that there's no improvement, and that special shoes, no improvement. And so we should ignore all of the evidence showing that misaligned feet leads to all of the pathologies within the feet, knees, hips, and back. Is that within the standard of care? I don't think so. So, and then think about all of the psychological and metabolic diseases. We should ignore all of that. So the standard of care is this. Your role as a physician is to be open and honest about what is the disease process, what are the available treatment options. So let's go over this. So when a parent comes in and you examine them and you take the x-rays, you should take 2 sets of x-rays, the neutral stance or even just a non-weight bearing and a relaxed stance to show the pathology. So what do we have? What's the difference? With the corrected stance, we have an aligned and stable talus on the calcaneus and navicular. And then we have the relaxed stance position where there is a partial dislocation of the talus on the calcaneus that forces the navicular to drop, that increases the strain on the soft tissues. This is a pathologic deformity. There's nobody on this planet that can tell me that this is a normal alignment. It is abnormal. We have excessive abnormal forces that are acting anteriorly versus posteriorly. So this is the root cause of pediatric flat feet. So this is what we tell our parents is that what's happening with your child's feet is that the talus is partially dislocating. And that's exactly what this is. It's a partial dislocation. The articular facets of the talus do not remain in constant congruent contact. So the forces that should be going posteriorly through the back of the calcaneus are now being thrust anteromedially on the navicular in the medial column of foot bones. This is an abnormality. So this is what we see. So this is scientifically proven to never get better, that we're going to get at least a 33% increased strain on the plantar fascia until it partially ruptures. Posterior tib, there's an increased strain of 51%. There's increased forces acting on the first metatarsal. That's why we get metatarsus primus varus and hallux valgus. The toes are flexing, we're getting compression within the portopedis and tarsal tunnel, and the nerve is being affected. So, and it's scientifically proven to affect the ankle, the knee, the hip, and the back. So there's many, many articles that have shown that. So again, talking to the parents, that even though people out there saying that you're going to outgrow this, there's no science to support that. These feet will never get better. They're only going to get worse. And what I had a landscaper tell me one time is take a picture of this tree because it's only going to look worse in a couple of years. Same thing for these kids' feet. They're never going to look better. They're only going to look worse. So what are the treatment options? Again, I'm not convincing anybody of any treatment options. My role is one thing, is to be open and honest with my patients and tell them what I know. What does the literature say? Not what my opinion is. I mean, I'm going to give my opinion as well, but my opinion is based on facts, not myths and misconceptions. So the observation, which seems like the easiest and the least expensive form of treatment, is the worst thing you can do. Because with every single step, we have excessive forces that are destroying the tissues within the feet, knees, hips, and back. And this is going to be the most expensive option because now we're going to have to spend so much money trying to fix all of these diseases, the tissue pathology within the feet, knees, hips, and back. Think about going to the chiropractor week after week to try to realign your spine and it doesn't do anything. Think about having an arthroscopic knee surgery and all of the physical therapy associated with that, only to have recurrence of knee pain. This is scientifically proven. This isn't me just blabbering here. There's studies out there showing this. So observation is the worst form of treatment. Arch supports, shoe inserts, again, they're better than nothing. There's going to have some support, but the evidence shows that they are not going to fix the problem. The other thing with arch supports and shoes is that there's compliance issues with trying to have the kids wear them. They outgrow them. You have to keep coming back and buying more and more, but there's still no literature to support that it fixes the problem. Because of the limitations of the previous conservative care, we have the traditional surgery of calcaneal osteotomies, lateral calcaneal lengthenings, medial column fusions. And for a lot of kids, they're just not severe enough for that. And the complications and risks associated with those surgeries, the benefits did not outweigh the potential risks. So if you're going to do this kind of aggressive surgery, we say, well, then you might as well wait. But again, that's not really the best thing to do either. So that's why another form of treatment was developed many decades ago. Unfortunately, a lot of the public is still very unaware of this treatment option. Now, a lot of surgeons are out there and they say, well, equinus is the root of this problem. However, there are still no studies to show that a tight Achilles tendon is the formation of a pediatric flat feet. It's associated with this, we see it very commonly, but it is the Telotarsal dislocation that is primary and the equinus is secondary. Number one, how can I support this claim? Well, number one, is there one X-ray that shows after a TAL or gastroc recession that an abnormal talar deviation with a transverse and sagittal plane deformity, all of a sudden that talus pops right back on the calcaneus and we have improvement of the radiographic angles? Zero. Not one case study that can show that. Number two is, let's just think about this. We know that the majority of kids, unless they have a true equinus where their heel is not touching the ground, that they have a functional equinus. Why does that happen? Well, you have ligaments that are around supporting the talus and the calcaneus, and when those ligaments are strained, that's going to force a muscle contraction. And one of the biggest muscle tendon complexes that are stabilizing the subtalar joint is the Achilles tendon and the gastroc and soleal muscles. So when the talus is abnormally dislocating, that's triggering the posterior muscle group to tighten up, and that is what causes an equinus, this functional equinus that just keeps getting worse and worse. So anyway, so let's talk about a real treatment and something that just makes total sense. And this is extraosseous telotarsal stabilization. Now, the reason why I do not say arthroeresis is because there's many different types of arthroeresis procedures. Now, I know that this specific webinar is for the international group. A lot of you are familiar with calcaneal stop. Now, calcaneal stop is not extraosseous, it's intraosseous. Now, calcaneal stop is used very commonly. The problem with it is that it is not a long-term solution. It is only available for certain age groups, and after 3 years at maximum, the screw needs to be removed because of the negative effects that the screw has to the talus. Imagine the talus smashing into the screw thousands of times a day. Eventually, it's going to cause pathology. There's been calcaneal fractures and implications from the loss of correction. So extraosseous telotarsal stabilization is definitely the way to go. So this is a spacer, it's a stent, and I use titanium with hypercure because there are some absorbables, but the problem with absorbables is that they just don't work, and a lot of them have been pulled off the market because they've been associated with an avascular necrosis of the talus. So it's reversible, unlike traditional reconstructive surgeries. Once you cut bone and put a bone graft in, you cannot reverse that. So as far as compliance issues, it's great. Unlike arch supports or special shoes, this is internal. So no matter if the kid is walking with shoes, without shoes, it's in there doing its job. When you compare the potential complications associated with EOTTS versus the traditional osseous reconstruction, there's absolutely no comparison. We know that there's literature that says within 6 months after a lateral calcaneal lengthening procedure, that there's already arthritic changes that are associated in the calcaneal cuboid joint. There's also then problems with the loss of the correction and with having to take children back for surgery to remove painful hardware. So anyway, so that's a big problem. And there's also limitations with traditional surgeries as well. But I'm not here to really talk about the traditional surgery. I'm here to talk about EOTTS, extraosseous telotarsal stabilization. Here's a child 2 weeks post-op. You can see the right foot has the hypercure placed into his foot, and the left foot still has to be corrected. Both feet look the same preoperatively. So what do you think? If this was your child, would you rather have your child with a hypercure in their foot? This is a better functioning foot. There's no strain on the plantar fascia posterior tib. They're not going to have the issues associated with that pediatric flat foot. So again, how can you say that that left foot is just normal? And that you can, I could never honestly look a child's parent in the face and tell them, oh yeah, don't worry about that flat foot. That's normal. That your child never going to have a problem with that. That's an absolute lie. Absolute lie. It's not if, it's when. So looking at the difference between the uncorrected and corrected, I mean, it's just obvious. So here we have this child walking. I slowed this down just a little bit and just think about all of the pathologic forces acting within the foot and ankle and the knees, hips, and back. And how could you ever tell a parent that their child's going to outgrow this, that it's going to spontaneously just fix itself, that there's not going to be any issues? Of course, that's not true. So I have to get the updated video. This child, since this video, has had both feet done, and so it's great. So unlike non-surgical forms of treatment that show absolutely no radiographic improvement, with the use of EOTTS, we can show that, not only with clinical observations, but radiographically as well. So we look at a normalization of the talar declination angle. We look at how we've elevated and restored the natural alignment of the navicular. And also think about the anterior deviation of the cyma and how that's increasing and weakening the forces acting on the medial column of the foot. So by putting in this stent in a 10-minute procedure, we've decreased the strain on the plantar fascia by 33%, decreased the strain on the posterior tib tendon by 51%, decreased the forces within the tibialis posterior nerve. And I mean, it's just, we've restored the foundation of the body. So what is the risks of a sinus tarsi implant? Really, the biggest thing that we've ever seen is that a patient can develop prolonged pain from the stent, because sometimes we can't just subsequently put in larger sizes. So if they have a severe deformity, we put in the size that they need. And so sometimes it can take a while for the patient to adjust to the new position, to the new alignment of their hind foot. So sometimes we have to go in and perform a revision or just permanently remove it. We have no significant complications. We have nobody that has ended up with a subtalar fusion as a result of a hypercure implant. Now, there's been one case study of a type 1 arthroresis device that this paper said that it turned into a spontaneous subtalar arthrodesis. But what happened in that situation, the spontaneous was a 3-year prolonged process where the surgeon failed to remove a completely displaced implant that, led to that complication of the medial and anterior facets. If the surgeon would have removed it initially when he first saw that the stent was displaced, there would have not been any problems whatsoever. So really, we have just that somebody has pain and that there's removal. There's been no other arthritis, no other issues, no calcaneal fractures, no talar fractures with hypercure. So what happens without treatment, with foregoing treatment, without performing any surgery? Well, we already talked about it. Spring ligament rupture, plantar fascial rupture, posterior tib rupture, tarsal tunnel compression, and portopetus compression, ending up with plantar neuropathy, first-rate diseases, increased forces acting on the first metatarsal, leading to metatarsus primus varus, hallux limitus, hallux rigidus, and hallux abductor valgus, metatarsalgia because of the abductor twist, flexor stabilization hammer toes, ankle pathology, osteochondral lesions of the talar dome, calcaneal apophysitis, growing pain, shin splints, and then all the problems with the knees, hips, and back, plus the metabolic diseases. So that's pretty significant. So when we look at the benefit risk analysis, the benefits are huge. We have internal correction, better than any kind of observation, muscle strengthening, orthotics, special shoes, without the risks associated with traditional rear foot reconstructive surgery. We still have normal motion. There are myths out there, and this just drives me absolutely nuts, that when you put in a sinus tarsi implant, that you completely restrict the range of motion. That's absolutely false. We have the normal amount of talotarsal joint range of motion. And we have all of the literature to show the normalization of joint forces, the normalization of weight-bearing forces, and the decreased strain to the tissues. The foundation of the body is restored. So we have positive effects of the body. So I've published these papers that we've had normalization of the triplane motion of the subtalar joint, reduce forces to the medial column. We prevent navicular drop sag. We elevate the navicular. We decrease the compressive forces acting within the tarsal tunnel and portopetus. We've positively decreased the strain on the posterior tib nerve, the plantar fascia, the tibialis posterior. We've normalized weight-bearing forces. And then recently, we showed that we decreased the forces acting on the medial tibial plafond of the knee with hypercure by 33%. It was nearly 33%, 32.8%. So there's absolutely no other method that has been shown to have such a positive effect to the foot and ankle, and now also to the knee. And we know that this will have a positive effect to the rest of the body. So if it's my child, I'm not going to just let them keep walking on those misaligned feet. And I'm definitely not going to do something like a subtalar fusion. So for me, and that was the initial thing, is I want to offer my patient an effective, scientifically proven modality. Observation, external devices are scientifically proven to be ineffective. EOTTS with hypercure is the only thing that is proven to be effective. So why do you want to wait until your patient needs a triple arthrodesis? Why would you do that? That is wrong. To me, that is below the standard of care. So when we take a look at, do we need to wait for symptoms? This is a very, very common question. You say, I'm only going to perform, I'm not even going to tell my patient that this treatment exists until they have symptoms. Well, no, that's not your role. Your role is to give them all the different treatment options, and it's up to the parent to decide if they want this for their child. But when we talk about painful symptoms, we have all these other diseases, and this is a disease within the foot and ankle, that we treat without symptoms. Think about it. Do you wait until somebody has a diabetic coma until you start treating their diabetes, or do you wait till somebody has a stroke to start treating their hypertension or heart disease? You wait till they have their first heart attack, and now you say, well, maybe we should start trying to figure out how to help your blood flow. So no, we treat these conditions. Again, our role is to be preventative, not just to be, wait till their tendons are blown out and then say, okay, well, maybe we should think about some other surgical treatments now. So this is a pathology, again, I keep saying it over and over. I'm a broken record. It never gets better, it gets worse. So we have all of the science to back up everything that I said, and you can go to our website that's at the bottom, hypercaredoctors.com, to look at all of the literature. I have hundreds and hundreds of articles to back up everything that I'm saying. Now, one of the biggest questions, and we already did a previous webinar on this, so I urge you, if you haven't seen that one, to go back and look at patient selection for EOTTS with hypercure. Now, it's not the same. Hypercure is a different kind of implant versus the other arthroresis implants on the market. So go back and do your own research. This is not a webinar for that. Anyway, so patient selection, we have to be scientific about this. So yes, they have to have a flexible hind foot, but we need to take weight-bearing x-rays, look at the talar second metatarsal angle, it needs to be less than 53 degrees, because if it's greater than that, we're not going to be able to normalize it. If they have a talar declination angle, they have to have a talar declination angle less than 42 degrees. If it's greater than that, then we're not going to be able to bring it back to normal. Now, both of those, we're going to make it better, but we're just going to make it normal. You have to rule out a tarsal coalition. So that's one of the biggest things, especially with pediatric patients. If they come in at 8 years old, well, you're not going to be able to see if they have a telotarsal coalition, because those don't show up till at least 12 to 14 years of age. And of course, we have to look at all the other secondary deformities. If they have a low calcaneal inclination angle, well, we need to address that. If they have a severe equinus, you need to address that. Or if they have hypermobile first ray, you have to address that. If you only treat one deformity, if you only put in a hypercure and you ignore all the other pathologies, then that can then compromise the results of the hypercure procedure. So I want to just answer probably some of these are some questions that are going to come up, but please do submit your questions to us. So are there any activity restrictions after you put in a hypercure? The answer to that is no. And I'm talking about no once they've healed. So everybody heals differently. We don't want to have any running or jogging till at least 6 to 8 weeks after the insertion of hypercure. It takes that long for the tissues to really adhere to the stent so it doesn't displace. But after that, we have marathon runners, basketball players, MMA fighters, soccer players, whatever, you name the sport, we've got somebody that has it, no problem at all. You have to remember that even though like on the x-ray, it looks kind of scary with this in your foot, but the 99% of the forces are acting on the articular facets. It's only a minimal amount of force that's acting on the stent itself. Now, the youngest age that hypercure has been placed into somebody's foot, it really boils down to one thing, is when does the sinus tarsi become ossified? And that's typically 3 years of age. So I know that we have several patients that have hypercure in as young as 3. Now, for a lot of surgeons out there, they kind of laugh and scoff at that. And sure, I mean, a lot of people wait till their patients are 8 to 10, 12, 14 years old. But when you have a child's foot that is so bad that they don't want to walk, that you've tried all these other devices, and they're really limited, you can say, well, why not? What's the worst thing that can happen by putting in this implant? Nothing. You take it out. Big deal. What's the worst thing if you don't put it in? Again, they're just sitting there and their tissues are becoming diseased. So anyway, so 3 is the youngest, 94 is the oldest. So some surgeons say that, you know what, you need to wait until the child is 18 years old, and then I would put in one of these implants. And that's just so ridiculous. Do you wait until you have 50,000 miles on your car tires to then balance the tire? Yeah, you want to balance that tire right away. So walking on misaligned feet for 10 years and what kind of damage that's inflicting into all those tissues just doesn't make any sense. So the sooner the better. Just like any disease process, you want to treat the disease as soon as possible before it gets too severe. Now, what happens with that child that you've put the hypercure into their feet at 8 years, 6 years of age, and now they're osseously mature? They're 21, 24 to 4 years old. Well, what we want to tell the parents is that it's unlikely that we will ever have to replace that stent. That's not a guarantee. You never know. But we know that the most common size hypercure 1 stent is size 6 and 7. That takes up about 90% of the sizes that are used in adult patients. So if you've already put in a size 6 or 7 into a child's foot, they already have the most common adult size. So that's why we say it's unlikely that we're going to have to replace that. So after 15 or 16 years of hypercure being on the market, we have not seen any cases where we've had to do that. Well, I shouldn't say any. There's maybe been 1 or 2 cases where the implant has become dislodged and they had to have a revision of that, but it's very unlikely. Now, one of the other questions too is what happens if you take out the hypercure implant after it's been in a few years? There are no published studies that I can talk about. The only thing that I can tell you is experience from myself and from other surgeons that say that sometimes the correction is maintained for at least 6 months to even a year. Other cases, the correction is lost almost immediately, even after the stent has been in for 1 to 2 years. So for me, it's we're still waiting for that. Hopefully we can get more papers published. So it's possible that the correction maintains. it kind of makes sense because the tissues are able to contract and become stronger, but we don't know the long-term follow-up of that. So that's all I have to say about it. So some general observations when using hypercure. We're getting to the last part of this. I know we've kind of run over a little bit. We're trying to keep this around an hour. Is some rules as far as, do you perform both feet at the same time, or is it better to perform one foot at a time? So let's talk about this. Now, mentally, it seems like it's better that if you take the patient to the OR one time, it's less of psychological issues to both you, the parents, and the child, just to go to the operating room one time versus having to go through the process twice. Even financially, it seems better if you take them to the OR once versus twice. But I'm here to tell you that I'm going to plead with you, whenever possible, that you do 1 foot at a time, 1 foot per surgical setting. And this is the reason why, is because when you do both feet at the same time, there's at least a six times longer than the normal recovery when you do 1 foot at a time. And that's because when you do bilateral surgery, the patients don't have one good foot to walk on. And it's normal after a surgery on the lateral aspect of your foot that you're going to guard your weight bearing and you're going to supinate the hind foot. And you're going to guard one foot more than the other foot. So now you're placing excessive forces on one foot greater than the other foot, and that increases the likelihood that one of the stents that can become displaced. So now that increases the likelihood you're going to have to take that patient back to the operating room anyway. Now, there's no evidence to show what kind of percentage of stent displacement occurs. That's just been my experience and experience reported to me from other surgeons. So again, we go back to your role as a consultant, and you present this information to the parent, and it's the parent that ultimately decides, are we doing both feet at the same time or 1 foot at a time? Now, when you do 1 foot at a time, it's a much faster recovery because the patients have one good foot to stand on. It's less likelihood of a stent displacement, going again back that they have one good foot to walk on. So now, the only thing with that, the one caveat, is when you do 1 foot at a time, that first foot is going to be painful until you internally correct the opposite foot. It's kind of like putting new tires on one side of the car and having the old tires on the other side. The new tires are going to wear out until you put the other new tires on the other side of the car. So when that other foot keeps flattening out, it's going to put a lot of pressure on the internally corrected foot. And you need to tell the parents and the child this before surgery, not after, because afterward, if they're still having prolonged pain and the foot you just put the hypercure into, they're going to be like, yeah, okay, you expect me to give you my other foot and to make that one as painful as this one. So just make sure that you tell them that when you do 1 foot at a time. Now, how fast can you do the other foot? Well, usually as soon as the patient can put full weight on that foot, which is usually about 7 to 10 days. Now, I've had, the soonest I've done the contralateral limb is 1 week later, but usually what the average is out there is about 3 weeks. So something around there. You don't want to wait too long. You don't want to say 6 months, 8 months, a year later, because that is going to compromise the results of the implant that you put into the foot. When we take a look at patients that have had a hypercure removed, usually it's a unilateral procedure. And so that doesn't really give hypercure a chance to work. It's a compromise. It's just a bad result. Again, it's like putting the new tires on one side and you never put new tires on the other side of the car. So give me a chance here. So the unilateral, shorter recovery, less likelihood of stent displacement, you're going to have better results. The only problem is you got to go back to the second time to the operating room. Bilateral, 1 trip to the operating room, but you're going to have a much longer than expected recovery, a longer period of abnormal gait recovery, and a greater chance of stent displacement. And overall, it's a less than ideal recovery when you do both feet at the same time. So that's all I'm going to say about that. It's up to you, to the parents, and to decide upon that. So anyway, so that's pretty much what I have for you. I hope that I've opened up your eyes to this condition, that you see now why it's important that we fix these kids' feet, and why we need to have much greater public awareness about the negative effects of pediatric flatfoot, and more importantly, that we have a minimally invasive option that internally corrects this, that is scientifically proven, not only just radiographically, but scientifically with the tissue strains to have such a positive effect to these children with misaligned feet. So with that, what I want to do is let's take a look at the questions to make sure that okay. So one of the questions that we have is, what is the age? And so I talked a little bit about that, of when do you recommend this? And what I want to do is I'd like to answer this one by giving you my experience of being out and traveling the world. One thing, it's great. Hypercure is in 73 countries, and it's because of how effective it is. So it's been really great. So what happened? So a lot of some surgeons will come up to me and they'll say, yeah, I refuse to put this into anybody under 16 years of age. And that's great, that's fine. You put it into the 16-year-olds. And then I'll see them at a meeting later. And I say, so what's your age limitation now? And usually what happens is it's dropped significantly. Because what will happen is they'll have a 14-year-old that'll come in, that's a beautiful candidate for a hypercure. And they say, okay, well, why do I need to wait for this patient to walk on these abnormal feet for another 2 years? So now they drop it to 10 or to 12, 14 years of age. And then I'll see him another year and I say, okay, how's it going? And how's everything now? What's your youngest age? And now they've dropped it again to maybe 8 years of age. And it kind of just keeps going down until now they're like 6 years old or so. I mean, we don't want to say that put this in every 3-year-old that walks into your office, but it just depends on their symptoms. I mean, this recurrent telotarsal dislocation, this is not a life-threatening condition. Nobody's going to die because of misaligned feet. So we never convince anybody to have surgery. We only educate them, and it's up to them to decide when they want to have this treatment done. So I hope that answers your question. One other thing too is I do want to put in another polling question here as far as how many of you, if you would like to be contacted or to have any other marketing materials, please let us know. You can visit us on our website, Hypercure Doctors. We have so much literature, so many ebooks, videos, we have online training. And so anyway, so we're here for you. We're here for your success. So, okay, so just kind of let that run. And after that, I'm going to hand it back over. Oh, we have something else?
One more question.
Oh, we have one more question. Okay, let me see if I can read. What about flatfoot in children with no values?
Valgus.
Oh, valgus, but neutral hindfoot alignment. Okay, so that's a great question. And that goes back to the radiographic studies, because you can have an abnormal talocalcaneal alignment without a calcaneal valgus. So I don't always look at the calcaneal valgus as do they have a flat foot or not. So look at the x-rays, and that's really what's going to show us. You can have a talar declination angle and that's abnormal and a transverse plane deformity. So we don't just look at one plane, we look at the triplane correction. So that's that. What?
Go to the Q&A button.
Oh, okay. Here. Ooh. So one other question that came up is, what is the role of physical therapy? And with that, usually we don't even recommend physical therapy after this, because the kids are just going to do their own healing. And sometimes what we find is that the physical therapy can be too aggressive. So that's usually not much of an issue. So great. Okay. All right. Well, thank you so much. If you have any other questions or anything, just please feel free to email us. Thanks a lot.